No, I am in another meeting. When that introduction is over, I will join. Okay. Oh, you start with the.
Om Gam Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganapati Bappa Moria
Om Gam Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganapati Bappa Moria
Om Gam Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganapati Bappa Moria
Good evening, Dr. Amitra. How are you?
Recording in progress.
Yeah, good evening, good evening. Hope you're all fine. Very good.
So this will be the. So this will be the.
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday.
So good evening, everybody. On behalf of the Endo Society of India, I have great pleasure in welcoming all the faculties, chairpersons, and President Dr. Pratip Kumar Mitra sir. So this is the 9th module of the webinar series what we are conducting on behalf of Endo Society. I think the previous all modules have gone very successfully and we have it in recorded version and we can always give the link so that those who have missed can see that. And today we have two great personalities, Kanti Madam and Dr. Sneha Boyer, who are going to be the moderators for today's session. And we have four speakers, that is Dr. Meenakshi Sundaram. She will be talking on role of ICG instead of adolescent endometriosis, which will be dealt by Dr. Subhash. And nerve sparing surgery in endometriosis will be by Polly Chatterjee. And second look in endometriosis will be by Dr. Gaurav Dosai. So with this, I hand over the session to the moderator. And the first moderator is Dr. Kanti Panchal. She is the director of Safal Fertility Foundation, Ahmedabad, IVF expert, and Snake IVF Center, Bhopal, Ahmedabad, pioneer in the field of ART in India and Gujarat, and produced the first IVF baby of Gujarat and Ahmedabad. The pioneer again in artificial intelligence, virtual reality, and haptics in ART. He has been awarded the RCOG Distinguished Service Medal, invited by Aspire as Working Committee member of Special Interest in Endometriosis, specialized in management of infertile couple, PCO, endometriosis, and women's healthcare. She has published 12 books on PCOS, endometriosis, infertility, and ART, which are used by reference for medical students, and published more than 30 scientific articles and 50 chapters in medical books. He's been a guide for PhD students, visiting faculty at Gujarat University. Successfully, she has trained 2,000 gynecologists in the field of PCOS, endo, and infertility management and ART. And she was the first chairperson for endometriosis committee of FOXI. And only with that, I got my acquaintance with Kanti Panchal, and I can say she is one of the most enterprising and very good friend of mine who has excelled in this field of PCOS and endometriosis. So next is Dr. Sneha Boyer. Over to Sneha Boyer is again, she's done her MBBS MD from Pune, managing director of Shukrata Hospital, Maternity and Surgical Nursing Home and Laparoscopic Center, and 34 years of experience in this field with a teaching experience of 5 years. And she has got so many awards and accolades from the national level and from the local, her society, her own society, and then from Maharashtra. And she has got extensive experience in conducting a lot of breast committee programs. And she has been chairperson of breast committee, governing council member, and she has got so many awards and accolades. And she has held her post in AMOX also, and more than 300 talks, 25 articles and chapters in national publication. She's a peer reviewer for Jogi and organizing chair for many conferences, and her primary investigator in fighting against cervical cancer in 2020 was the research coordinator of Ankur project, research in menopause and research in cervical cancer. So with this introduction, I hand over the session to the moderators.
Yeah. Thank you so much, madam, for that kind introduction. Very good evening to one and all, respected President of Endometriosis Society of India, distinguished office bearers of ESI and TNFOG, and of course the scientific chairperson, Dr. Ramani Devi. A very good evening to one and all. It's my privilege to welcome all of you. Let me congratulate for having this specific topic of adolescent endometriosis. We have been observing that, over decades, severe dysmenorrhea in adolescents, it has been dismissed as normal menstrual pain. And today we know that endometriosis is actually, getting delayed diagnosis for almost 7 to 10 years. In fact, if we diagnose it earlier, if we evaluate it earlier with appropriate imaging, it can treat with judicious use of medical therapy, and of course, whenever needed, the fertility preserving surgery. So today's scientific program has been thoughtfully designed to address some of the most relevant issues and challenging aspects of adolescent endometriosis. I'm sure the topics have been very well chosen, and so as the faculties as well. So we are privileged to have the eminent panel of experts. So let us learn together, and I sincerely congratulate all the organizers once again. Thank you so much, and let us move ahead with the scientific session.
Just a minute, Dr. Sneha. I would like to say a few words. Good evening, all the delegates who are listening to this wonderful session. First of all, hearty congratulations to my dear friend, Dr. Ramani Devi, for having this exquisite webinar series on behalf of the ESI. And there are also excellent speakers today. And just to say a few words about the adolescent endometriosis, the prevalence is around 70%. It is unbelievable, but it is 70%, and we have to be vigilant and catch these youngsters to prevent further problems. And it is common and often very, very underdiagnosed cause of pelvic pain, and because of the delay of treatment and delayed diagnosis, there are long-term health impacts. Surgery is generally reserved, in adolescents, because there is a saying that the operative procedures should be as less as possible in cases of endometriosis, possibly just once in the lifetime. So when pain is resistant to medical management, that is the time where you have to adopt to the surgical treatment. Or in some cases, if the teenagers have advanced stages of the disease, like advanced, the endometriomas, which are not really getting cured by the medical treatment, that is the time when we need to go for surgical treatment. But it's, however, a very interesting webinar today as far as endometriosis. I'm a hardcore medical therapy person, but then I would love to hear people talking about surgery in these cases. And then we have a next, please, can you show the first speakers? Like, yeah. So we have Dr. Meenakshi Sundaram for this first lecture of adolescent endometriosis. And so I'll be introducing her as course director for fellowship in endoscopy, TNMGR Medical University, OGSSI managing committee member, IAG managing committee member, TNIAG joint secretary, gold medalist under graduation and post graduation from Tamil Nadu, Dr. MGR Medical University, extensive publications in peer-reviewed journals and several book chapters, operative faculty in various national conference workshops, received Icon of Tamil Nadu Award in 2023, winner of Mrs. Mediqueen Bharat International Beauty Pageant 2025. Congratulations, Dr. Meenakshi, and please start with your presentation.
Thank you, ma'am. Thank you for those kind words. I would be sharing my slide. Actually, I will be speaking on the role of ICG. So there is a swap of topic between me and Dr. Subhash. So I'll be speaking on the role of ICG because we use a lot of ICG now. So I'll just share my screen. Yeah, so you can see my screen now.
No, it's not completely. No.
Yes.
Yes, you can see my screen. Fine. So basically, I thank you, Endometriosis Society, and thank you, Ramni Madam, for giving me this opportunity. I'll be speaking on the role of ICG in endometriosis. We know that ICG is basically indocyanine green. It is a water-soluble dye that is visible only under near-infrared light, the NIR. So the first time ICG was introduced was for basically robotics. So this was way back in 2011 when we got the Da Vinci Robo, the Firefly technology they used to call it, because the NIR mode, with that NIR mode you could identify ICG when given in tissues. Now, if you look at the role of ICG, it can be used for advanced laparoscopic and robotic procedures. It is not a replacement for any meticulous surgical technique, but it enhances the visualization. It also shows the tissue perfusion, and it helps identify the important structures, making the surgery more safer and more precise. So how does ICG basically acts is whenever ICG is injected, it binds to the plasma proteins, it travels through the blood, and when the near infrared light falls on it, it gets excited and the ICG starts fluorescing. So this, either you can give it via blood or you can give it through the structures. Like we in endometriosis now started using ICG into the ureter directly, so that you can visualize the ureter because of the fluorescence. You can put it into the bowel directly. You can visualize the bowel margins exactly because of the fluorescence. And we have also extended its use. Sometimes when you give it intravenously, if the endometriotic spots are highly vascular, you can identify those spots. We can use it for an isthmocele identification if you put it intrauterine, and we have used it also in a couple of cases for adenomyosis excision. If you want to know where the cavity is and how deep you have to go, you put it into the cavity, you know where to stop your dissection because the cavity will fluoresce. So these are all the roles of ICG that can be used in gynec practice. So I will limit a couple of my talk to specifically in endometriosis how we have been using ICG. So earlier we were doing it mostly only with the robotic system because it had the Firefly. But now if you see over the last few years, even the laparoscopic systems have the ICG near infralight mode. So if you change in your laparoscopy, if they have the ICG mode, if you change to that mode, you will be able to see the fluorescence of the dye into the specific structure. So the advantage now in the laparoscopy system is they've brought in an overlay mode where you can even see the tissues normally in their normal color, and the ICG is overlaying on those specific things, which can be either green color, blue color, whatever you want to see. Usually it's the green color that fluoresces. Yeah, so this is what we do normally. So my couple of videos here will be showing how we are using this for endometriosis. So this ICG is a 25 milligram powder in a vial. You put in 10 ml of sterile water into the ICG and you dilute it. So you take totally 10 ml of the solution. We put 5 ml into each of the ureter. So sometimes if you feel it's only one side ureter that is involved in your surgery, then you can only put in the dye through that side ureter. If it is bilateral endometriosis, you can put it in both the ureters. We put in the ureteric catheter, we push the ICG 5 ml into each ureter. You can just take out the catheter immediately. You don't have to leave the catheter. You just have to put it, just like tubal cannulation, put it into the ureteric orifices, push in the dye and remove the ureteric catheters. So this is a young girl who came with fever, endometriotic cyst. As we dissected, we realized that this was an endometriotic cyst on the left side, and with the history of fever, there was a suspicion of a possible infection. You can see that along with the endometriotic fluid, there is probably some element of pus as well. So we took this for culture sensitivity. It was an infected endometriotic cyst. So we have released that entire ovary. We all know that endometriosis also causes a lot of pelvic inflammation. So you can see here in this particular case, we have put in the ICG into the left ureter. So we put the ureteric catheter into the left ureter before itself, put in 5 ml of the ICG dye. This stays for about 2-3 hours till you finish the surgery. So as you dissect, you can see that the ureter is well down. You can trace the ureter almost till the lower level. So thereby the ICG is very useful to detect this, and that entire ovary was removed. That's the ureter. So this is again endometriosis, multiple adhesions. So in all these cases, all these are the first few cases that I'm showing are all robotically done. There are dense adhesions all over the abdomen. We've done adhesiolysis. And always in endometriosis, it is important that you go to the lateral pelvic space, open up the spaces, because these are relatively the virgin spaces. You open the lateral pelvic space, identify the lateral structures and the ureter. This was a case of repeat endometriotic cyst. This patient was actually 40 years. She had multiple endometriotic surgeries on the same side. The right ovary was involved. So this time we had planned to remove the ovary. So you can see the ureter, and we had put in a dye there. I think it just jumped to the next video. Alright, so this was another case of endometriosis. So here we sometimes in young girls, because you cannot do effective vaginal manipulation, you can use this Medilift, the T-lift. When you do this, you can, the Mediflex lifter, this helps in lifting the ureter so that your POD is exposed. So this actually reduces one port or one port that you want to use during the surgery, and you can also avoid the vaginal manipulation. Now you know that the uterus is up and the POD is exposed. So that is the complete adhesiolysis that we had done. In this case, we also actually put in ICG into the rectum for identification. So when you want to do rectal adhesiolysis, you proximally occlude the rectum, put a 30 number Foley inside, block it, and then you can put in diluted ICG into the rectum. You see the firefly mode, you know where the uterus and the rectum is adherent. You will be able to identify the margin of the rectum because of the ICG inside the fluorescence. You can go in the correct plane and then do a complete rectal adhesiolysis. So this is laparoscopically a video that shows an overlay mode. So in robotic, we don't have the overlay mode. You will have to shift between the ICG mode and the regular mode. In laparoscopic systems, there is an overlay mode where you can first put in the ureteric catheter, you push in the dye, and simultaneously, when you are doing the regular laparoscopy, the overlay mode helps in identification of the ureter that is fluorescing. So here you can see slowly that as we are releasing the adhesions from the endometriotic cyst, and we are trying to identify the ureter, we have put in the ICG through the ureteric catheter, and slowly you can see that the right ureter starts fluorescing. So this is an overlay mode. In this mode, you can identify both the ureter while you are doing the surgery, whereas in robotic, you will have to shift from the ICG mode to the regular mode to continue the surgery. So here you can see the green color ureter. So you know that as you are continuously dissecting the endometriotic cyst of the lateral pelvic wall, you are careful and you know that the ureter is not damaged much. So this is another case where we use ICG, especially cystic adenomyomas. This was one interesting case of a cystic adenomyoma. Again, the patient presented with acute pain and it was actually diagnosed as an adenomyoma, but when we saw there were dense adhesions of omentum over the anterior uterine wall, we dissected all these adhesions and found that the adenomyosis was on the anterior wall and it was multiple pockets of adenomyotic tissue. So there you can see almost the uterus was looking like cystic spaces all over, multiple adenomyomas on the anterior wall. We excised all those adenomyomas. It was difficult to sometimes identify the uterine cavity. So putting ICG into the uterine cavity helped in fluorescing the uterine cavity. So we were able to limit the dissection up to the level of the uterine cavity and then reconstruct the adenomyoma bed. So these were all areas of cystic adenomyosis that were excised. So here you can see that that's the fluorescence of the endometrial cavity. That is, so we have excised all the adenomyotic tissue, and with that we then go and approximate the uterus. So the other important thing of ICG is assessment of tissue perfusion, especially if you want to do bowel endometriosis and excise. Now, sometimes in endometriosis, if you're doing a segmental resection of the bowel, then for re-anastomosing, you need to know that the perfusion on either end of the bowel is good so that there is no anastomotic leak. So in these cases, you can put the ICG intravenously. You look for perfusion in the proximal and the distal end, so you know which is the diseased area and you can excise that particular area for anastomosis. Similarly, we have done for bladder endometriosis as well. If you want to see the edges for reconstruction suturing, when you give it intravenously, the healthy areas fluoresce, and when you anastomose those portions, then the leak rates are very less. So the uses of ICG in endometriosis can be either directly into the ureter, it can be directly into the bowel, it can be directly into the uterine cavity for adenomyomas or identification of the cavity. And intravenously we can use it for especially in bowel anastomosis or sometimes bladder repair or endometriotic lesions in the peritoneum which are highly vascular, they can specifically fluoresce with intravenous use of ICG. So with this, I would like to conclude and say that ICG definitely is not a replacement, like I said, for routine surgeries, but it definitely helps in making the surgery very precise and very meticulous, because you're able to identify the vital structures. Because most of the time when we are doing ovarian endometriomas, our main worry is the ureter. When you know the ureter is away, you can do a lot of dissection on the lateral pelvic wall and remove all the diseased tissue, especially when you're doing butterfly peritonectomy or peritonectomy in the areas when you know exactly where the vital structures are, especially the ureters, then the disease clearance is much better. So I'd like to conclude by saying all these challenges are done with a very good teamwork. Thank you. Hello.
Neha? Yeah.
Ma'am, can you hear me?
Yeah. But your voice is low.
Hello.
Yeah.
Yeah.
So it was a wonderful presentation
Thank you.
with all these where we use ICG. What happened to Kanti madam? Give your opinion.
I think madam is
Muted.
Ma'am, you're on mute.
Muted.
Ma'am.
Madam.
She joined the audio. Can you hear Dr. Meena?
Yes, ma'am, I can hear
Yeah,
you.
yeah.
Sneha, yes.
That's an excellent presentation.
Thank you.
It's definitely a subject that's really, I think the voice is going, I don't know. But the subject which definitely needs better coverage and needs different approach. I'm very happy that you I congratulate you all.
Thank you, ma'am. Thank you so much.
Thank you so much.
So move on to the next topic, madam.
Kanti madam. Yeah, so there you are. You please introduce the next speaker. Or you want me to introduce? Whatever.
I will introduce, because after this maybe I'll have to leave. Thank you, Sneha. So our next speaker is none other than Dr. Polly Chatterjee, and she is consultant at Manipal Hospital and also Columbia Asia Hospital, Salt Lake City, Kolkata, trained in India, UK, Germany in advanced gynecological endoscopic surgery. Member of AAGL, that's from USA. Limca record holder for removing maximum fibroids from a single uterus. That's wonderful. Recipient of ISSN International Best Researcher Award in Medicine 2025. Oral presentation at ACE conference in Bali, Indonesia 2024. Conducted many hysterolaparoscopic workshops and has helped many state and national level live workshops and conferences. She has presented and published many papers and also the author of 2 books and contributed chapters in international books as well. Presentation at FIGO in 2012, 2015 and 2025. Video presentation at RCOG World Congress at Birmingham in 2017 and London in 2019. Welcome, Dr. Polly, and kindly go ahead with your presentation.
Thank you so much, ma'am. Thank you. And first of all, I would express my gratitude to all of you over here and Dr. Pradeep Mitro and Dr. Pidash Mahapatro, everyone who has given me this opportunity for presenting. This is my topic is nerve sparing. Let me share my screen. Just a minute. The share screen mode. Just a minute, I have. Can you see my screen?
Not yet, ma'am.
Are you
Jignesh,
seeing my
can you
screen?
have? No, not yet, ma'am.
Not
Not
yet.
able to see. Jignesh, can you help Dr. Polly?
Yes, I see. Ma'am, you see there is a share button in the downside. Ma'am,
Yes.
click
Just a
the
minute.
share. Okay.
Are you able to see my screen?
Not yet, ma'am. You are not started sharing yet.
Okay, just a minute. I have to reduce this. Just a minute.
Okay, ma'am.
In my show, just check to share this screen.
I think you should send the PPT to the organizers. They can share it from there. Ollie?
Just share for
उनको भेज दो तो वो करेंगे.
हाँ.
It will be easier for you.
I'm not having the share screen thing.
No,
Yeah.
it will be at the bottom.
Ma'am, you come on the Zoom screen. Leave the presentation screen. Come to the Zoom screen. On the Zoom screen, there is
Yeah, I got it. I got it.
Yeah.
Yeah. Sorry.
Yeah, now it's come.
Now it's come. Sorry.
No worries. Go
I'm
ahead.
so sorry for that.
It happens many times. Yeah, it's
Okay.
there. Yeah.
Yeah. So thank you so much for everything. And my topic is nerve sparing surgery for endometriosis. Just like we are doing a cancer surgery, endometriosis also involves dissection of bowel, bladder, and sometimes we have to go for bowel resection. And in those cases of deep infiltrating endometriosis, we need this type of nerve sparing surgery. Now, which nerves are involved? Which nerves are we thinking about? It is a pelvic neuroanatomy. Those are the network of somatic and autonomic nerves controlling the lower limbs, perineum, and the pelvic organs. Key structures are the sacral plexus, pudendal nerve, inferior hypogastric plexus, which manage urinary, bowel, and sexual functions. Now, when we come to this picture, all of you can see just below the aortic bifurcation, we have this. Can everyone see the screen? We have the superior hypogastric plexus over here. And from there, from the superior hypogastric plexus, we have the two nerves coming down. Those are the hypogastric nerves, one on the left and one on the right. And over here, these are the sacral splanchnic nerves. And we have the pelvic splanchnic nerves, which carry the parasympathetic fibers. And when they come below, near the pelvic floor, they become they form the inferior hypogastric plexus. So superior hypogastric plexus is a continuation of the aortic plexus, supplying the sympathetic fibers from the spinal levels T10 to L2. And the hypogastric nerves are a pair of nerves carrying the sympathetic fibers down into the pelvic cavity. And the pelvic splanchnic nerves are the parasympathetic fibers originating from the spinal levels of S2 to S4, S2, S3, and S4. Inferior hypogastric plexus, that is a pelvic plexus, are the major integration hub. They are blending the sympathetic and the parasympathetic inputs to supply the bladder, rectum, and the reproductive organs. Now, what are the objectives? Why are we talking about this? We need to do a complete excision of the endometriotic lesions, and we need to preserve these nerves. We have explained all the nerves, the superior hypogastric, the hypogastric nerves, and the inferior hypogastric plexus, so as to reduce. So these nerves will supply the bowel, bladder, and will help in the sexual dysfunction. So we have to spare them. We should not cut them. So what are the indications where we need all these things? In the deep infiltrating endometriosis affecting the bowel, bladder, ureter, and the pelvic nerves. We have the parametrial diseases involvement, rectovaginal septum endometriosis, where there is uterosacral involvement, where there is bowel or ureteric endometriosis requiring radical excision. Now, very important is the preoperative mapping of the endometriosis. And the most important we can do with a good expert TVS ultrasound, and MRI scan is the best possible method. And also, where there is bowel involvement, where there is bladder involvement, where there is ureteric involvement, we have to be planning multidisciplinary, and we should involve the neurosurgeon, or we have to involve the GI surgeon as well. Now, what are the surgical principles in this? We develop a avascular pelvic spaces. This is very important. What are the pelvic spaces? They are the spaces which are lined in both ways by fascia, like avascular, they're avascular. There is no blood vessel inside it, but and there is fascia above and fascia below, between the two layers of the fascia. And what are the spaces? They are pararectal, paravesical, Okabayashi, Latsko spaces. Early identification of the ureter and the hypogastric nerves. Meticulous dissection along the fascial plane, preserving the nerves while attempting complete excision of the disease, and avoid excessive thermal injury by using precise energy application. Now, this is a video showing how to identify the hypogastric nerve and how to dissect them. So basically, thinking about the hypogastric nerves, we should always start from the sacral promontory. And this is a very nice area. It's a holy plane where there is least adhesion. Most of the patients will not have any adhesions over here. So we start from the sacral promontory and go along the side of the ureter, and we open up the peritoneum over there, and we go up to the level of the uterosacral ligaments. So just opening up the fascia over there. And while opening the fascia, you can see this structure very nicely over here. See, this is the pinkish fine structure. It's very easy to understand and easy to locate. And this is our hypogastric nerve. So there are two hypogastric nerves. So once we dissect out, we go dissect and go deep into the, up to the layer of the hypogastric fascia and the levatorani muscle. And again, we are taking the incision above and cutting the peritoneum at the level of the sacral promontory. And as you can see, we just open up over here. This is a layer. See, this is the, you can see with my marker, I'm showing you, this is the nerve going there. So this is the hypogastric nerve. And as we are dissecting down, as we will get all the other small branches. And so this is the nerve over here. I'm going to just continue a little bit. So once we can hold this nerve very gently, not pinching, but very gently, we can hold the nerve and we dissect medially again. And you can see gradually small cuts. We can just separate this nerve from the medial portions. And these are all the fascia. Over here, we don't have any vessels or anything over here. So we are just separating the nerve from here. And you can see over here in the next slide, when we go a little bit ahead. So from the sacral promontory, yes, we dissect further down and we will be able to observe there is a nerve bundle over here. And this is a Y. See, one side hypogastric nerve and this is a left side dissecting over here. This is very important space, and over here you can have the left-sided ureter going from this side, and we have to just take care we don't injure them. So as we can, so see here we can just pull this up and we can find out that we have this. This is a bundle. This is from the aortic bifurcation. It is coming down. This is one side and there is the other side. So it's like a Y-shaped nerve. So dissection of these nerves, we should be doing in all the cases of endometriosis, especially where there is a lot of adhesions. And see, this is a Y. This is one right-sided hypogastric nerve, and this is a left-sided hypogastric nerve. Now I'll go to one of our conservative operations we have done. We are regularly doing this type of cases. We start with the hysteroscopy. She had lots of polyps inside. And when we went in, we had this picture. So the tube, the ovaries are coiled up and they're all adherent over there. So according to our endometriosis, the operative principles, we always go from the lateral pelvic wall. We flip the sigmoid colon from the left side, left lateral pelvic wall. And the next structure we have to see, we find out the ureter. So once we find out the ureter, we have to lateralize the ureter. So lateralization of the ureter is our second. So this is, see, this is our ureter. We are lateralizing it. And on the medial side of the ureter, we can see those nerves. And this is the posterior wall from the uterosacrals. And this is a uterus posteriorly. The tubes and ovaries are being separated from here. And we are pulling this up to make the anatomy normal. So by blunt dissection and sharp dissection, we are making the anatomy in the normal place. So tubes and ovary on this side has gone on the normal place, and now we are lateralizing the ureter. See, this is the ureter, and we are going to lateralize it on the, this is on the left side. Similarly, on the right side, we are separating the ovaries from the uterosacral ligaments and the uterus, and we are separating them. Because of dearth of time, I'm just going to harm. So with the help of blunt dissection and sharp dissection, we are taking the ovary back to normal place. So now we are opening up the lateral pelvic wall. And this is from the medial side. And again, we are going to lateralize the ureter on this side. And here we are separating the rectum. We have a rectal probe inside the rectum, and we are separating the rectum over here from the posterior surface of and we are going to open up the POD. Means we are going to separate the pouch of Douglas from the details. The rectum has been taken down. So once we have done that, now we are going to excise all the peritoneal structures and this endometriotic nodule over the uterosacral ligament and the posterior part of the. So you can well understand this is our pouch of Douglas, and we are going to just make the anatomy normal, and then we see beautifully the rectum has been taken down. So little by little we can attain this dissection very nicely. So as you can see, this is the uterus, and we are making the anatomy of the tubo-ovarian mass. We are making the anatomy normal. And in the last part, I would like to show this. We are taking out the nodules from the uterosacral ligament. So this is how we do the conservative surgery. And at the same time, now in this video, I'm going to show you how we do the surgery by nerve sparing. So this was an adenomyotic uterus and with the bowel adherent to the posterior wall. And again, we are by sharp and blunt dissection, we are separating. And over here, you can see we are separating the ureter. Ureter is being lateralized, and by the side of the ureter, you can always see this hypogastric nerve. So we have to safeguard this hypogastric nerve. And as we dissect out gradually by sharp and blunt dissection, we can find out, see, the nerves going over there. So when we started at the beginning of our career, we never used to see the nerves, and we used to think it's very difficult. How can we see the nerves? But as we gradually continue and our eyes have become, we can see what the mind doesn't know, the eyes cannot see. So as we are going on doing it, we can understand which is a nerve, which is a fascia, and which is the vessel. And we can always find out the nerve and we can separate it. So it is only by practice. Practice makes you perfect. So very nicely, you can see all the sacral nerve roots can be seen over here. And we can see the S2 and S3 sacral nerve roots. And you can separate them, and you can just, without cutting them, or you can just lateralize them before you go for the main operation. So this is on the other side. We are separating the ureter, and again, we are going to find out the nerves on this side. So these are the inferior, this is the inferior hypogastric nerve. Again, as you can see, very nicely dissected down. And this is a pararectal space dissection. As you all know, the pararectal space is lined on the medial side by the rectum, on the lateral side by the iliac vessels, and deep below the pararectal space is lined by the levator ani, and caudally on the back, and it is formed by the aortic bifurcation area, that is a sacrum, the sacral promontory area. So again, we are separating this, and lateralization of the ureter is very important. And you can always see the ureter, beside the ureter, you have the nerves over there. So that is it. I'm not going into details of this. So what are the limitations? It is technically demanding with steep learning curve, and it requires advanced laparoscopic expertise. Nerve sparing surgery may be difficult if the nerves are extremely infiltrated with the disease, and it takes long operating time. Now, what are the complications that can happen? We can have bladder dysfunction, we can have rectal injury, we can have constipation or bowel dysmotility, bleeding, ureteric injury, recurrence of endometriosis if we leave something behind. Now, what is the evidence? Most evidences are from observational studies. The randomized control trials are limited due to technical and ethical challenges. Cohort studies and systematic reviews show nerve-sparing surgeries achieve pain relief and recurrence rates comparable to the conventional radical excision when performed by experienced surgeon. ESHRE, ESG, ACOG recommend referral of complex deep endometriosis to specialized multidisciplinary centers with expertise in nerve-sparing surgery. Now, what are the key takeaways? Nerve-sparing surgery is a preferred approach in today's endometriosis surgery. Subspecialty procedure, it should be best performed in high-volume endometriosis centers by surgeons experienced in advanced pelvic neuroanatomy. You should know your anatomy better. You should know anatomy. This is the most important thing we must know. Training is essential. We must be able to identify the ureter, the uterine artery, hypogastric nerve, inferior hypogastric plexus, pelvic splanchnic nerves, rectovaginal septum, and all the pararectal, all the different spaces. And this we can do by going for cadaveric courses. I should say this is very important. You can never learn all these things in a live patient. Always we should think about the cadaveric courses, and we must have more cadaveric courses. Thank you so much for your patient hearing. I've given this picture to show you the bowel and the bladder, both are there in endometriosis. And so we should have a brave heart to deal with them. And now we also have the nerves. Thank you for your patient hearing.
Thank you, Dr. Polly Chatterjee. Your, lecture was as clear as a crystal. Initially, I thought, oh, what will I have to thank Dr. Ramani. She always helps me out. I never thought I will sit through because I'm a medical person. But I have seen my patients suffering so much because, I'm sorry to say this, but these surgeons, including all my friends also, I think they operate left and right, and then they come to us and say it is paining here and it is paining there, and then we don't know what to do. But today I sat and saw all the small nerves, the big nerves. I really, really enjoyed.
Thank
So
you so
nice.
much,
It
ma'am.
was very nice, your lecture. I was thinking that this girl doesn't know how to start a PPT and what
Thank
she's
you.
going to show about nerves. But amazing work, amazing. I think your husband is with you, right? For work?
Yeah. We both work
Got his
together, and
name.
we are doing
So,
everything together. Yeah.
excellent combo.
Dr.
Excellent.
Abhinish.
All
Thank
the
you so much,
best.
ma'am. And thank you.
Madam, I always used to appreciate Polly and Abhinesh for their excellent surgical work, especially in deep infiltrative endometriosis. And
Thank you so
that's
much.
why I called Polly. And previously also Abhinesh had given a talk in the same web series, madam.
Very
Thank
nice.
you, Polly.
Thank
Okay,
you so
let
much,
us
ma'am. Thank you for the opportunity. Thank you.
next we'll move on to the next speaker, Dr. Gaurav Desai. I think he has to leave by 5:15. So
Yeah, you can introduce.
yeah.
Yeah, so it's a pleasure to introduce Dr. Gaurav Desai, whom we all know, practicing obstetrician gynecologist, pelvic endoscopist, and robotic gynec surgeon. Works at Bridge Candy Hospital, PET Hinduja Hospital, and the Gleneagles Hospital, Mumbai, and he's the assistant professor, St. GS Medical College, KM Hospital, and he's the author of
Hello.
Yeah.
Physics and Gynecology. He's got over 12 national and international awards. Yeah, managing council member. Hello, Dr. Gaurav. We have already.
Yeah, hi, madam. Can you give
Yes.
me just 5-10 minutes? I'll just set up my laptop.
Okay, so we have already introduced you. So we look forward for your talk and eager to listen to you. Over to you, Dr. Gaurav.
Yeah. Give me just 5 minutes. I'll just set up my talk.
Dr. Ramani, madam, do you want to make
Yeah.
some comments before he starts?
I am also more a medical person for endometriosis, though I do some to some extent endosurgeries, but all these dye surgeries are very complex, and I feel it should do it in a center of excellence only. And today we saw Dr. Pauli's surgery and Dr. Meenakshi Sundaram, and now we are going to see Gaurav, and subsequently.
Somehow, Dr. Ramani, I feel these are institutional surgeries.
Yes, definitely.
Definitely.
Because whatever surgery now, Dr. Gaurav is going to talk about second look surgery.
Yes.
I'm sure even when you operate endometriosis primarily, sometimes you find, that the frozen pelvis, it is so difficult to even identify the structures anatomically. Operating on these structures is really difficult. And whenever you want to take a follow-up of this surgery, whenever you have to go for a second look surgery, I'm sure it's going to be much more difficult. So we are really eager to listen to you, Dr. Gaurav, and definitely we would love to watch.
And believe me, most of these patients do require a second look. I've seen that. They come with so many complications. The pain never goes away. Then we advise for second look.
Endometriosis is an ongoing disease.
Yes.
We always say that
progressive.
You have to have a plan, medical as well as surgical.
All aspects it has to be attacked.
Yes.
And more than that, it starts from home and ends only at tomb. Because don't think that menopause is going to be the end of the endometriosis.
Exactly. That's what the next comment was from me, that previously, maybe as a UG, we used to feel that, once you remove both the ovaries, along with the uterus, or maybe once a patient becomes perimenopausal, endometriosis will be over. But since now we are into the field of, going as faculties also, we are reading more and more, we are going through all the researches. There is no age bar, even for postmenopausal women, it's continuation of the process.
I'm also wonderstruck at the rate this endometriosis and more so adenomyosis is growing in apartments. Every OPD I see at least 2 or 3. I'm not very happy seeing them, but the people say, how do you diagnose? Because it's there staring at you. What do you do? They have come for a baby with so much of problems in their uterus and pelvis. It's so
adolescent girls also now I come across adenomyosis even in very young girls. 16, 17, 18, they will come with progressive dysmenorrhea, and you can see that early evidence of adenomyosis.
I agree.
Dr. Gaurav, are you ready?
Yeah, I'm ready. I'm just loading my.
Okay.
Sorry for the delay. Can I share the screen?
Yes. Share your screen.
Can you make me the host?
Jignesh?
Jignesh, please.
Hello, ma'am.
Make Gaurav as a co-host.
Yes, ma'am.
Okay. Try now, Gaurav.
Doesn't let me just check.
Sir, you can share. Click on the share button.
Yeah, I got it. Okay.
Yeah.
Yes.
Yeah. Okay. Can you see my PPT? I'll make it.
Yes.
Yes, sir.
Make it full screen.
Yeah. Okay, so at the outset, I'd like to thank Ramani Devi Madam and the organizers of this platform for giving me the opportunity. I think it is well established from all the talks that endometriosis is a complex challenge that all of us are facing, and uh, none more so than minimal access surgeons, gynecologists in India, which is now facing epidemic and pandemic proportions of this complex disease. So the topic which is given to me is a very interesting one. I would like to thank Madam for this. The topic is second look surgery in endometriosis. Is it a dead concept or is it precision medicine? So I will present evidence, controversies, and future aspects of this particular topic. So when we look at second look surgery, we have to really ask ourselves, especially gynecologists who have been practicing for decades, have basically come across second look surgery as an entity to check the progress, check the success of the primary surgery. But now in 2026, we have to ask ourselves, is it really a concept that is still alive, or is it intelligent precision medicine? So in other words, should we abandon this or should we redefine this entity called second look surgery? Now it is a good question to ask that if recurrence occurs in nearly half of the women, why has second look laparoscopy almost disappeared? There are also many other questions that we as gynecologists have to ask ourselves when we are treating our patients with endometriosis. Some of these questions are, if MRI shows recurrence, but if patient is pain-free, should you operate again? Is complete excision truly possible in microscopic inflammatory disease? See, we are basically excising the disease that is visible to us in our, now of course, initially it was the focal length of our eye. Today it is the high definition laparoscopic or robotic cameras, but there is a significant amount of disease that is not visible by HD cameras. So in true words, complete excision is very rarely possible. The next question is, have we replaced unnecessary second look surgery with unnecessary MRI surgery? Should recurrence be defined by symptoms, imaging, biomarkers, or surgery? Could AI reviewing the index surgical video identify patients who need re-intervention better than what surgeons do? Is the real second look no longer laparoscopic or minimal access, but actually molecular? Are we measuring the wrong endpoints? Should quality of life replace the lesion recurrence or the primary outcome? If robotic surgery enables more complete initial excision, will recurrence rates mean that they are declining, or is endometriosis fundamentally a chronic systemic disease that we just have to accept? So let's look at the historical evolution of this particular topic. In the 1980s, there was a routine second look laparoscopy which was performed. Imaging technologies hadn't developed as much as they have right now. So people remember, I mean, in fact, I also remember some senior gynecologists always used to say, let's have a second look laparoscopy to see if the disease has recurred or not. Then in the 1990s, there was the assessment of adhesions and recurrence. By 2000, organizations like ESHRE and ASRM moved away from routine surgery. And in 2026, you have MRI, high definition, TVS, AI imaging, medical suppression, and also fertility preservation that has come into play. So has technology replaced second look or simply changed its indications? So what is second look? It is a scheduled laparoscopy after surgery. It could be a diagnostic second look, a therapeutic second look, maybe a second look laparoscopy before an IVF or before or after a bowel surgery, maybe a second look after an ovarian endometrioma, a second look after a fertility surgery. So the point I'm trying to get across is researchers, academicians, clinicians have analyzed these different aspects, but they are completely different in their scope. So the research papers that are there need to be compared like for like. So why initially was second look popular? Because it used to detect recurrent disease, treat the residual disease. Sometimes you have to lyse some adhesions, restore fertility, assess the completeness of the initial excision, evaluate newer drugs. Maybe you were trying to evaluate certain newer drugs that were coming in for endometriosis as a research endpoint of an academic study. So the question is, which of these goals is still required today? So endometriosis recurs, but does disease recurrence equal symptom recurrence? So pain recurrence is almost in 20 to 50% of cases. Endometrioma per se recurrence is about 10 to 35. This is what literature says. Deep disease recurrence can also occur. It is lower after a complete excision, but may need reoperation in up to maybe 1 out of 4 cases. So it is right to say that radiological recurrence does not always equal to symptomatic recurrence, and this does not always equal to need to get operated. So what is the biggest mistake? Surgeons treat recurrence. The patient actually seeks relief from the symptoms. So disease does not equal to pain, and pain does not equal to visible disease. The disease that is visible may not actually need surgery in all cases. Food for thought should be that should we operate on just MRI findings? So now what is the evidence against routine second look? So all these organizations, ACOG, RCOG, ESHRE have not given any recommendations. There is no RCT that has shown that second look improves pain, improves live birth rate, reduces recurrence, or improves quality of life. So why did routine second look disappear? Because of these reasons, and also the fact that it had no proven benefit. It needed an extra anesthesia, extra cost to the patient. It was basically a burden on the healthcare system in developing as well as developed countries. There had extra complications, adhesions which were caused by the second surgery, risk of extra ovarian damage, and a psychological burden to the woman. So can a procedure without outcome benefit remain ethical is a question we have to ask. But are we missing residual disease? Studies have shown that residual microscopic disease, residual fibrosis, residual nerve involvement, occult lesions, and incomplete excision can be missed. So should residual disease always be removed? But residual disease does not equal a failure. Now, residual lesions may remain dormant, respond to hormones, but never actually become symptomatic. So not every lesion of endometriosis deserves to be excised. Now, second look before IVF, there is a historical belief of removing adhesions that improve fertility, but the current evidence shows that routine second look before IVF has no proven benefit. IVF success depends more on factors like the age, the AMH, embryo quality, not on small residual lesions. Now, a second look after endometrioma surgery has some potential concerns. These include a residual cyst, recurrence, reduced ovarian reserve, and an AMH decline. So one has to ask, would another surgery improve fertility or worsen it? When we come to deep endometriosis, when can second look actually make a difference, or when can it matter? In cases of bowel shaving, extensive bowel surgery, discoid resection, segmental resection, ureteric surgery, bladder reconstructions, persistent symptoms despite the deep endometriosis primary surgery, any stenosis or a leak which has been suspected, and if you are suspecting symptomatic residual disease. So it is not a routine, but is problem-driven and specific cases. In case of adhesions, one has to remember that adhesions develop in almost half of the cases of operated endometriosis. Second look adhesiolysis, which initially appeared promising, but adhesions frequently can develop. So can imaging replace second look surgery? High resolution TVS, MRI, 3D ultrasound, all these technologies are now at our fingertips. You have sliding sign AI, which can be used, even robotic vision, which can play a very big role. So has imaging now become actually the second look? AI and digital surgery can change our treatment of endometriosis over the next decade. You can have a video review, you can have lesion detection, residual disease mapping, and various computer type of visions, which are now going to be the future. So if a woman has severe pain, severe bleeding, suspicion of malignancy, ureteric obstruction or obstruction of the bowel, an abscess which has developed, complications and infertility with unexplained findings, then yes, second look can still make sense. Malignancy is an unfortunate rare occurrence in endometriosis and needs staging, a second look surgery, which becomes necessary oncologically, and is a basic different, entirely philosophical management. Now, coming to the economics, a routine second look will mean a hospital stay, OT time, anesthesia, indirect costs, which can be a burden on the healthcare system of a country like India. So it has no proven gain, and health economics oppose a routine use. From the patient perspective, the patients usually ask, is everything gone? And a surgeon might ask, should I look again? But a better question is, will looking again actually improve the life of that particular patient? So patient-centered care is important today. Robotics is also there for us to access, and I routinely do these robotic surgeries. Does robotic change the equation? Yes, it has superior vision, dexterity, nerve preservation, and a better deep pelvic access. Now, if the index surgery is better, will we need fewer second look surgery? That is an important question. So the primary surgery is extremely important that it has to be well done. So the need of second look will reduce. So where does future research direct us? There should be more research into persistent inflammatory biomarkers, which can serve as guiders to recurrence of endometriosis. AI can play a big role. Molecular phenotyping is important, genomics, microbiome, and all these are very important, not just the fact that a precision surgery is done. So there is now a paradigm shift. The old philosophy is to find disease, remove disease, repeat the surgery if it recurs. But today, the philosophy is improved quality of life, personalized treatment, and operate only when necessary. Okay. Clinical decision algorithms have also changed because of the advent of good improved imaging technology, where these have taken a large chunk of these indications of second look surgery. So the take-home message is routine second look laparoscopy is no longer evidence-based. Recurrence does not always require surgery. Symptoms and not imaging should drive the treatment of a woman with endometriosis. And modern imaging has replaced many of the diagnostic indications of second look surgery. A second look remains valuable only in carefully selected patients. The future basically lies with biomarkers, precision medicine, AI, and individualized care, and not routine reoperation. So thank you for your time and attention.
Thank you so much, Dr. Gaurav. I think you have finished it in the right time.
Thank you.
Thank
Thank you, madam.
Unmute, madam. Unmute. I totally agree with you, Dr. Gaurav. The thing is, we can go in for a first surgery that should be the best. You should do
Yes.
it in a center of excellence.
Yes.
But by doing the surgery, you are removing whatever things you are seeing, you are regaining the anatomy.
Yes.
But what is the basic cause for endometriosis? You are not taking it off. Either the genetic changes, epigenetic changes, retrograde spell, nothing is altered. So that's the main reasons why you are getting recurrence. And that is the condition that where you need to suppress constantly with the medical management. I think
Yes.
Dr. Kanti will also agree with me. It is
Yes.
at least for a minimum period of 2 years, we need to suppress the patient post-operatively with medical management unless she is in need of fertility.
Yes.
I
In fact,
agree.
if you take the biopsy of the tissue that looks normal, it will actually under microscopy show endometriosis.
Yes.
It will show endometriosis. Yeah.
Yeah.
So Gaurav, excellent talk. I think you are, if not more than Sham, but nearly at par. His parents are my very good friends, Ramani.
Okay, I know
Sham
that.
and Meena from long back when I was doing my after my internship. Yeah. So nice. Where is he? He's gone.
No, no, he has some work at 5:15,
Okay,
so he
that's
was very
okay.
keen that
Yeah,
he could
but this
finish
is
before
going
that.
on very well, Dr. Ramne, really nice.
Thank you,
I
thank you,
never
madam.
thought I'll sit for the surgical, but it's so interesting.
So he has put in clearly when you should go for repeat surgery. That
Yes.
is the most important one.
But
So
the
yes,
point that you said was also very correct, that it's very difficult to, not to have a second look, and it goes on and on and on. And then, and what he said was another very important point, that even the normal tissues have.
yes, underlying, yeah. Okay, so then, Sneha, any comments?
Yeah, me too agree with both of you, because I am also a medical person, not operating endometriosis so much. Definitely the primary surgery should be in the center of excellence. That we have a consensus, I think. And you make sure that most of the surgery is done completely. And as you said, we have to suppress at least for a period of 24 months. I think that should be the very clear message, because the process is ongoing. So we have to suppress the patient at least for a period of 2 years. We all of us make a consensus. I think I have to leave for an emergency, so please excuse me.
Okay.
Thank you.
Subhash, are you there? Yeah. Subhash, have you joined?
Can't hear him.
Can't see.
Can't see
I'll
him.
just call him.
Yeah. All these youngsters are too busy.
Madam, he is not picking up the phone. So what we will do is, we'll just discuss today, being a surgical topic, we'll discuss what are all the conditions, I mean, how to go about with an management of adolescent endometriosis.
Yeah.
See, actually, 5 to 10% of the women with endometriosis, they are in the adolescent group. Okay.
Now it is around 20, Ramani. I just read.
Yeah, maybe it is increasing. And most often it is associated with adenomyosis also.
Yes.
Okay. So then the first line, the diagnosis is basically any girl, young girl coming with progressive dysmenorrhea and in sexually active dyspareunia and diffuse abdominal pain. I think these three are the most important signs in
What
adolescent.
about your, I always remember Dr. Ramani Devi's 7 Ds.
Yeah, these three, I'm coming to that. These three are the most important symptoms of adolescent endometriosis. But beyond that, you have dysuria, dysphagia, difficulty in conception, and dysfunctional uterine bleeding. And this will this will lead to depression, okay,
Yeah.
and fatigability. So the thing is, when the patient comes with progressive dysmenorrhea, we need to investigate. But most often, we don't see any imaging evidence unless the patient has got an
So
endometriosis.
just a minute here. What about the congestive dysmenorrhea? That is also.
Yeah, that congestive dysmenorrhea we have to rule out because congestive dysmenorrhea, just by giving NSAIDs, most often it subsides and it is not progressive in nature. That is the most important thing. We have to differentiate congestive dysmenorrhea from dysmenorrhea of endometriosis, which may be triple dysmenorrhea. That also we need to pick up. So for this, we are doing an imaging. First thing, get the history. History gives you half the things. Then
Yes.
you go to the imaging. Imaging, you can
Actually,
get
the problem in today's era, history is totally not remembered at all.
forgotten. It is
So
totally forgotten.
directly they put the APS, PV, nothing, physical science, it's very upsetting. Directly they put the probe in the vagina. That's it. It is not the way.
So we need to take a history, and also important things are when the patient, a girl has got school absenteeism. That is a very, very
Yes.
significant point. And suppose if the same girl is in slightly at the later age, school work absenteeism, that also matters a lot. There are studies to say that if there are more than 17 days of work absenteeism or school absenteeism, we need to think about endometriosis.
At
So
this
then,
point, Dr. Ramani, I wanted to add one more thing.
yeah,
Most of these adolescents are not able to tell properly to the gynecologist or the doctor.
yes.
So we have to probe the, mother to get the proper history
Correct.
and also the friends, because sometimes if we won't tell properly.
Hmm.
Yeah.
Okay.
Subhash has come.
So Subhash has joined. I don't know. Okay, let us continue, madam. Let us make it as a dialogue. That's all. That will be more interesting. So
Yeah.
this imaging evidence is there. Okay, we are treating straight away, starting to treat the patient with medical management. And if there is no imaging evidence, but when there is persistent symptomatic thing, we need to rely upon certain biomarkers. Because
Yes.
though the ESHRE 2023 says that there is no place for biomarkers in routine clinical practice, still under research we can do it. But I'm sure the next ESHRE revision will give importance for
Yes.
biomarkers. And now we have the biomarker, that is the microRNAs, which are dysregulated in endometriosis, irrespective of the stage of the disease and irrespective of the duration and the phenotype of the lesion. They are dysregulated. So you can take it as a point to treat the patient for endometriosis. And madam, can you tell me what are all the medical managements, what you will prefer in adolescent girls?
Yeah, so it's a very difficult question, but I'll try to answer. So in a younger age group, why it is difficult, first let us understand, because still the growth is not complete. Then we have to be double careful, because the bone growth and other things will be disturbed if we go on giving, GnRH agonists, etc. So most probably what will be really good is, first of all, we have to properly diagnose that this is a case of endometriosis or adenomyosis. And I think the best bet will be to give these girls a medical management.
Yes.
We should not go for any surgical. That is my take. Not because I'm not doing surgery, I'm referring left and right. I wish you were here in Ahmedabad, I would have sent all the cases to you. But then, if we should not keep on repeated surgeries, we should not do. So coming to your point, as you already told, we should first of all, when we before diagnosing, give them NSAIDs and all that, and then you come to know, no, they are not getting any sorry, any benefit out of it, that means it is diagnosed as a endometriosis adenomyosis, then we should go ahead and give them medical management. Medical management that we know of, Dynogest. Dynogest is, I don't know, you can correct me if I'm wrong. Initially Dynogest, and then we now these days we also have endogolics, etc. But all these things we cannot give for a very long time. We have to be very careful and also give them calcium and also vitamin D, all these things along with that, and carefully monitor these girls. Yeah.
Yes. So I found out one presentation on adolescent endometriosis. I thought I can share it, madam. Okay.
Please.
So
Yeah.
before, so this was what we did for Foxy Reach programs, what we did. I'll share that.
Yeah.
So this is presentations and diagnosis of adolescent endometriosis. Pardon? This is often an under-recognized, ignored, mislabeled in adolescent population, around 5 to 10%, and 10% of the girls are still asymptomatic. And atypical presentation is more common. 25 to 50% of the girls with dysmenorrhea and atypical abdominal pain of chronic nature have endometriosis. Frequently, it results in chronic pelvic pain, adhesive disease, and infertility. It is seen in 50 to 70% of the teenagers undergoing laparoscopy for evaluation of chronic pelvic pain and dysmenorrhea. That means if these patients with chronic pelvic pain and dysmenorrhea, if they are put diagnostic lab is done, then you find the lesions in 50 to 70%.
So
but
we need to strongly, the suspicion should be very strong.
Yes. So there is no need to put in a scope, but clinical suspicion is enough to start the patient on treatment. Then early diagnosis and, I'm not able to see. Okay, if early diagnosis and treatment may decrease the disease progression and prevent infertility. So why we are so much bothered about adolescent endometriosis is because there's the lot of economy is lost by the ENDOCA study that was done by World Endometriosis Research Foundation. They said that 0.8 to 12.5 billion euros are spent every year. Work, study, social and sexual relationships are affected, and 256 million women in the world suffer from endometriosis, and in India alone we have 50 million women. So now let us see what are all the risk factors for adolescent endometriosis. First thing is, when the girl attains menarche at an early stage, frequent and prolonged cycles, girls with low BMI, whenever there is family history of endometriosis, almost it is 7 times higher incidence, and severe dysmenorrhea where OC pill is used as analgesic and not as a contraceptive. So the first line management for adolescent endometriosis is, when there is suspicion, we need to put them on oral contraceptive pills. That will definitely suppress the pain, but we need to understand that this OC pill is going to only suppress the pain, but the disease, underlying disease is not going to get cleared, and it is going to have its roots growing on and on inside the girl's womb. Then pain that is interfering with the daily activities. That is an important point. Dysphagia and deep dyspareunia in sexually active girls, school absenteeism, and the most important one as a history taking, neonatal uterine bleeding. This was the theory that was put forward with by Dr. Eva Brosens, who says in girls who are having the newborns who are having neonatal uterine bleeding, they are at a higher chance of developing endometriosis in future. So generally, when we see neonatal uterine bleeding, we think that it is probably because of the maternal withdrawal of the estrogen. But now we have to understand that these girls are likely to go in for endometriosis in future. Let us see what the ESHRE guideline says. In adolescence, clinicians should take a careful history, what Madam has mentioned, to identify possible risk factors for endometriosis, such as positive family history, obstructive genital malformations, early menarche, and short menstrual cycle. And clinicians may consider endometriosis in young women presenting with cyclical absenteeism from school and use of OCPs for treatment of dysmenorrhea. So then there is often a delay in diagnosis. The start of the symptoms. So again, we need to say this delay in symptoms may range from 1 year up to 7 or even up to 9 years. This again, the delay in diagnosis depends upon what is the phenotype. For example, if the patient has got a scar endometriosis, then maybe we will be able to pick it up within a short time. But patients with early or superficial endometriosis, it may take a long time. And even similarly, ovarian endometrioma, they may take 4 to 5 years. So then ultimately the patient will hop off from one physician or a family physician to the pediatrician to the surgeon. And finally, when the correct diagnosis is made, it would have taken a lot of time. So this will affect the quality of life, affects the future fertility, and period of delay may be up to 7 to 9 years. So the types, even in adolescent girls, we have peritoneal endometriosis, ovarian endometriosis, deep infiltrative endometriosis. And in deep infiltrative endometriosis are not uncommon in adolescent. Nearly 1/3 of them are likely to have it. So then again, the adolescent girls, you can have early onset adolescent endometriosis or late onset. Early onset is probably because of the retrograde spill where it starts much earlier. At the onset of telarchy itself, she starts developing that. The late onset, it may be beyond 15 years or 16 years. So the clinical symptoms are not, as madam says, it's a 7Ds plus depression and fatigability. And the patient may have, likely to have multiple symptoms in the same patient. So the girl can have a cyclical pain, acyclical pain, she can have dysuria, dyspareunia, and so on. So the diagnosis is mainly clinical, then comes the radiological, and of course, we have been discussing about the biomarkers. So how to evaluate? One is by history, next is by examination, third is by imaging, and finally it is the biomarkers in future. So the components of history taking in diagnosis are, we need to understand the characters of pain, location, onset, magnitude, timing, quality, radiation, precipitating and elevating factors, and the duration. Urinary and bowel symptoms, fever and chills. Past history of treatment for gastrointestinal tract, genitourinary tract, pelvic infection, even a psychiatric problem, we need to think about it. Menstrual and contraceptive and sexual and gynec history, family history, interference with the pain and daily activities, pain diary should be maintained. Madam, are you able to listen to me? Madam?
Yeah, I'm just
Okay. Okay, you are able to see my screen, no? You are able to see my screen?
Yes, Dr.
Okay.
Ramani. Then my
Okay.
nurse came in between, so I got disturbed.
Okay. So the physical examination, you have to rule out Mullerian anomaly, which is found in 5 to 11% of the young girls. Abdominal and rectal examination. Q-tip test is nothing but to find out transverse vaginal septum by putting a small bud inside the vagina, and or ultrasonogram is going to be a must. And 32% or 1/3, I said already, the patient may have endometrioma or die. So diagnosis is mainly by therapeutic trial in adolescent girls with dysmenorrhea. Earlier, a therapeutic trial of NSAID and oral contraceptive pill. I think now we have moved on to the GnRH analogs and the Dynages. Beyond the age of 16, we can use GnRH analog. But in younger girls, say at 12 years and onwards, Dynages will be the ideal one, because we have the Visada study that was done in young girls in many centers, where Dynages was given for the 2 milligram per day for a period of even 2 years. Now we have got evidence to say that Dynages can be very safely used for years together, and the longest study was found to have more than 8 to 10 years. So then the imaging. Imaging, we can see unilateral or bilateral kissing ovaries, unilocular or multilocular, thin pictate septum, and the mobility is restricted, which you can identify by doing a transvaginal ultrasonogram according to the IDEA group, and elicitation of site-specific tenderness may be there. Mural echogenic module is very, very important, because it is an evidence to show that this patient has to have a watch. These mural elements are supposed to have an increased incidence of malignancy, and low-level internal echoes and posterior acoustic enhancements as called as a ground glass appearance is seen and nodular wall thickening. So 3D and 4D or color Doppler can help to differentiate an adnexal mass of maybe a dermoid, or you can even find out the germ cell tumors which are common in these adolescent girls. Of course, transabdominal or rectal ultrasonogram, you can find out the endometriomas and deep infiltrative lesions where the rectum is being pulled. And according to the IDEA group study, we can see the narrowing of this lower gut rectum and the anal canal that can be pulled out, and all these things are evidences of rectal endometriosis. So there is a high sensitivity of 90% and specificity of 100%. CT, of course, has got a limited role. MRI, I think everybody is for MRI when we want to plan a proper surgical management. And MRI is specifically done in adolescent girls when you are not able to pick it up by a routine ultrasonogram, or when you have doubt regarding whether it is an endometrioma or whether it is a germ cell tumor. Now we have the PET scans that can also pick up very early endometriotic lesions, and AI based ones in ultrasonogram and MRI AI application can help us in defining more precisely the diagnosis of endometriosis. So the current options for medical management are, you can start the patient with cyclical COCs in superficial peritoneal implant and ovarian endometrioma, or the ideal one will be the continuous COC, persistent dysmenorrhea despite cyclical COC, you can go for continuous ovarian endometrioma, and postoperative suppressive therapy, you can use it. But beyond that, progestins are the first line, they are ideal. Patients with ovarian endometrioma, dyspareunia, and COC intolerance or ineffectiveness or contraindication, we can use progestin and postoperative suppressive therapy. Dynages represents a valid option in cases of NITA intolerance. And as we have discussed already, beyond 16 age, we can use GnRH agonist or antagonist. And of course, we now have the lot of antagonists which are available with us, which can be used combined with the add-back therapy. This is going to be the second line. And in resistant cases, maybe as a third line, but generally in adolescents, we don't use, we can go in for a letrozole. So now let us see what are the indications for laparoscopy in adolescents. So this is a laparoscopic view of a 19-year-old girl who came with persistent dysmenorrhea, not responding to routine medical management. And this girl needed, so this is one patient where we can go in for surgical management. So then other thing is endometriosis that is associated with Mullerian anomalies, because we have discussed that Mullerian anomalies, 5 to 10% of the patients are likely to go in for endometriosis, and there are also situations where there can be rupture of endometrioma. So this, I have had patients with a 19-year-old patient who came to me with very high, who was referred as a ovarian tumor with very high levels of CA125, and the past history revealed that a patient was having progressive dysmenorrhea, and finally she turned out to be a rupture endometrioma. Then in recurrent endometrioma, Gaurav has already made it a clear point that we need to maintain it surgically, medically rather than surgical management. So when you have suspicions regarding the malignant nature, then we need to go in for surgery. So this is the end view of this patient. So then the preoperative evaluation, AMH, should be done because we are more bothered to maintain the fertility. Detailed imaging is a must. Senior surgeon should do, and no laparotomy, only laparoscopy should be done. And the principles to be followed during laparoscopy are: aim at eradicating the lesion. Then A, maintain the ovarian reserve and promote fertility, relieve pain, and prevent the recurrence. In cases of extensive ovarian endometriosis, clinicians should discuss the pros and cons of fertility preservation with women with endometriosis. The true benefit of fertility preservation in women with endometriosis still remains unknown. But still, in this era where women delay the pregnancy, I think it is a good option to give them a suggestion regarding fertility preservation in young girls or adolescent girls undergoing endometriotic surgery. So here, during surgery, we need to be more radical or less radical. If you are going to be more radical, you can impair the ovarian reserve. Less radicality will increase the recurrence. Now, coming to Mullerian anomaly and endometriosis, the incidence is more when the patient has got obstructive anomaly. In non-obstructive Mullerian anomaly also, that is in septate uterus, biconjugate uterus, still we have a higher incidence and of endometriosis when compared to women without Mullerian anomalies. This is probably because of the abnormal or dysarchimetra where the wave wave will be different. There will be retrograde peritoneal spill may be more. Adolescent girls with early onset dysmenorrhea have to be investigated for endometriosis. So this is a very interesting case of Erlen-Werner-Wunderlich syndrome, where there was a unilateral obstruction at the cervical level. Cervical agenesis she had, and she had an hematometra. So this patient had early endometriosis also. You can see endometriotic lesions here. So this particular patient underwent hemihysterectomy. This was done quite a long time back. And because there was cervix was not there, I need to go in for a hemihysterectomy. And finally, ultimately, the hematometra was removed, and this girl repair was done, making right hemi. This right side hysterectomy was done, and left side horn was maintained. So this is a case where there is ipsilateral renal agenesis and endometrioma. So this is again a Robert's uterus, very rare one, first reported in 1970, where you can see this was a third surgery what I am doing. Here you can see here there is presence of tube and ovary on one side, and there is no tube and ovary on the other side because it has been already removed, thinking in terms of endometrioma. But in the hysteroscopic view, you can see only one horn and there is a bulge. See, actually it is a case of atypical septum where the lower end of the septum gets inserted into the ipsilateral side. And here, by cutting this, by using a Collins knife and cutting this septum, we can make, see, at one point, the septum, once when it is cut, it is discharging the collected blood. And now I had made the septum, that the residual septum was resected and the cavity was made single. And then see, and this was a final view. So finally, this girl had a very good relief of the endometriotic symptoms because the atypical septum was cut. So finally, to say endometriosis roots in utero, starts at 20, progresses at 30, problematic at 40. Why I say problematic is it has got a high chance of developing earlier onset of cardiovascular and cerebrovascular problem and supposed to end at 50 and malignant risk at 60 and needs ever follow-up. So thank you for the stopgap. I could say at least some points about the adolescent endometriosis, and the definite indications are like large endometrioma not responding to medical management. Second one is when it is associated with Mullerian anomaly, because we can treat the disease completely, it can almost revert it. And then third one is when you are suspicion about the malignancy, and the fourth one is when you have a ruptured endometrioma. I think.
You wanted to add a few points.
Yes,
Dr.
yes, madam,
Very
because it was a
nice,
short presentation.
yeah, very nice lecture. Nicely made PPT. Very easy to understand. I think as far as adolescent endometriosis is concerned, the main crux is diagnosis. We have to diagnose. And for that, even if you give an injection of GnRH agonist and see whether the pain decreases, that is one thing. Second,
Yes.
I wanted to include in your slide is that we should also get CA-125 done so that we know the prognosis of that patient.
Yes.
So that is one more thing. Otherwise, I think the medications and all what you said was very right. I still remember that rupture endometriosis
Endometrioma.
case where the CA-125 had gone way
Yes.
high. So whenever I get a little bit higher CA-125, I always remember you. And nowadays, I think many of these youngsters also come with endometriomas, big endometriomas, both the sides. So yes, Dynogest, I used to call it a wonder molecule. Still today it is. It's very easy to give just a oral, but in very difficult cases or where it is extended endometriosis, we can also combine the medications. Like, we can give for a short period, not long periods, like
Yes.
Dynogest and agonist for a short period. Of course, we have to take care of the age and all that. Yeah, excellent. I like the last presentation.
Okay, now Pallavi, can we move on to the MCQs? Because it is 5:30 now.
Yes,
Okay.
ma'am.
Yes.
Yes, ma'am. Jignesh,
Can I
Jignesh,
leave,
please
Dr.
proceed for
Ramani?
Yes, madam, you can leave. Thank you so much for staying
you.
with us for so long.
It is so interesting. I don't even like to go now, but then I need to take care of my patients as well. Thank you. All the
Thank you
best.
so much, madam.
Thank you.
Thank you.
Yeah.
Dr. Polly,
For,
can you give your inputs in adolescent girls? Dr. Polly? Yeah. Dr. Polly? Polly Chatterjee. Okay, otherwise then we will move on to the MCQs.
yes, ma'am. Jignesh, please start quiz.
Okay, ma'am. Just give me 1 minute.
Hmm. So now let us start the MCQ. Which is the strongest current indication for planned second look laparoscopy after complete excision of endometriosis? A routine assessment of recurrence after 12 months, histological confirmation of hormonal treatment response, persistent symptoms with inconclusive imaging where surgery is likely to alter the management, improvement of spontaneous fertility in all patients. What is the correct answer? So the answer is, you give some time for the participants. Jignesh, why it was done so rapidly? So the
It's a 30-second over, ma'am.
okay. So the current indication is persistent symptoms with inconclusive imaging where surgery is like to alter the management. Okay, move on to the second question. Which statement best reflects current evidence regarding routine second look laparoscopy? One is, it significantly reduces the recurrent rates. It improves long-term pain outcome in most patients. It is not routinely recommended after complete excision. It improves IVF outcomes irrespective of the disease severity. Yeah. So the answer is, it is not routinely recommended after complete excision. So Dr. Gaur has clearly given at this point that it should not be routinely recommended any second look laparoscopy. Okay, then move on to the third question. Which investigation is most likely to reduce unnecessary second look surgery in suspected recurrent deep endometriosis? CA-125, PET-CT, expert transvaginal ultrasonogram, diagnostic hysteroscopy. Correct answer is expert transvaginal ultrasonogram with bowel preparation is likely to give an idea about the recurrent DIE. Next question. Which patient is most likely to benefit from second look? Asymptomatic women with stable residual endometrioma, persistent infertility with normal imaging and no symptoms, suspected recurrent ureteric obstruction due to DIE, and patient requesting confirmation of complete disease clearance. So who is going to benefit? The correct answer is yes. Always in any patient with ureteric obstruction due to DIE or additions, we have to go in for a surgical clearance, because otherwise it might lead to silent renal failure. Next question. Which development has most reduced the role of routine second look? Routine post-operative CA-125 monitoring, advances in expert imaging, individualized medical treatment, universal use of robotic surgery, routine post-operative MRI surveillance. Yes. So the correct answer is yes, advances in expert imaging. So, and individualized medical therapy. Yes, next question. Which pelvic nerve is most important to preserve, reduce post-operative bladder dysfunction? Femoral, hypogastric, ilioinguinal, and genitofemoral. Dr. Polly has clearly given this answer in her lecture. Correct answer is hypogastric nerve. Next question. The preferred first step before excising deep infiltrative endometriosis is immediate bowel resection, ureterolysis, retroperitoneal resection, oophorectomy, and appendicectomy. Correct answer is yes. Ureterolysis and retroperitoneal dissection is very, very important before starting dissection for DIE. Next question. Which imaging modality is most useful for preoperative mapping of DIE? X-ray chest, MRI pelvis, mammography, CT brain. Those who are answering should do it within a matter of 1 or 2 seconds. The correct answer is yes, obviously MRI pelvis. Next question. The main advantage of nerve sparing surgery is smaller incision, reduced bladder, bowel, and sexual dysfunction, zero recurrence, no bleeding.
मीटिंग अटेंड कर रहा है.
Dr. Sudha, please mute your phone. Correct answer is reduced bladder, bowel, and sexual dysfunction. Next question. Which surgical platform is increasingly used for complex nerve sparing endometriosis surgery? Lithotripsy, colonoscopy, robotic assisted laparoscopy, and histosalpingography. You should not take more than few seconds, not milliseconds, to answer this question. The correct answer is robotic assisted laparoscopy. Next. Which is the primary indication for surgical intervention in adolescents suspected of having endometriosis? As a first-line diagnostic test before any medical management, chronic pelvic pain unresponsive to 3 to 6 months of empirical medical therapy, as soon as the patient reports severe dysmenorrhea during her first period, to routinely check for the disease progression every 2 years. So again, the correct answer is chronic pelvic pain unresponsive to medical management, empirical medical management. Next slide, please. which is an 16-year-old female presents with severe cyclical pain and hematometra. Ultrasound reveals a transvaginal septum. What is the most immediate surgical priority? Diagnostic laparoscopy to stage the endometriosis, extensive pelvic stripping, surgical correction of obstructive reproductive tract anomaly, long-term GnRH therapy without surgery. It's a very simple question. Transvaginal septum. Next priority is surgical correction. Just open up the transvaginal septum. It can treat the patient. Next question is, compared to adults, what is the most characteristic visual appearance of early endometriotic lesions typically found in adolescents during laparoscopy? Powder band black lesions, clear red vesicular superficial lesions, large cystic fibrotic puckered scars, DIE involving the bowel. Correct answer is clear red and vesicular superficial lesion. 14th question flow. Next question. According to 2022 ASHA guideline, what is recommended regarding the surgical technique for managing adolescent endometrioma to preserve ovarian reserve? Routine oophorectomy, drainage and coagulation, ovarian cystectomy or carbon dioxide laser vaporization is preference to simple drainage, vigorous bipolar coagulation of the entire ovarian bed. Correct answer is ovarian cystectomy with laser vaporization is the preferred one than simple surgical drainage. Next question. What is the known long-term risk of performing repeated multiple ovarian cystectomies for recurrent endometrioma in young girls? Development of endometrial carcinoma, severe depletion of ovarian reserve, premature ovarian insufficiency, increased risk of multiple pregnancies in future, permanent hypertrophy of the uterus. Correct answer is repeated surgery will lead to severe depletion of the ovarian reserve and POF. Next question. What type of light energy is used to excite indigocyanine in green molecules to make them fluorescence during laparoscopic endometriosis procedure? UV light, near infrared light, standard visible white light, high intensity X-ray radiation. So the correct answer is near infrared light. Next question. When evaluating a bowel segment before performing discoid or segmental dissection for rectosigmoid endometriosis, what is the primary purpose of injecting ICG intravenously? To stain the stool inside the colon a bright green color, to assess the real-time tissue perfusion and vascularity, ensuring the healthy blood supply to the anastomotic margins, to chemically dissolve the endometriotic nodule without surgery, to measure the patient's immediate GFR. Correct answer is to assess the real-time tissue perfusion, vascularity, and integrity. That is the most important one. 18th question, next. During retroperitoneal dissection for DIE, how can ICG be utilized to prevent accidental intraoperative injury to the ureters? By injecting ICG intravenously to turn the entire retroperitoneum green, by inserting the ureteral catheter and instilling the ICG retrograde, causing ureter to glow brightly under near infrared light, by spraying ICG directly into the pelvic frame through the open incision, ICG cannot be used to visualize the ureters. This also Meenakshi had made it very clear. So the correct answer is, we could see her inserting the catheter and then instilling ICG. So the next question is, what is the major advantage of using ICG enhanced fluorescence angiography over standard white light laparoscopy when searching for occult or atypical peritoneal endometriotic lesion? It causes the lesions to grow larger instantly. It highlights the areas of hypervascularity and abnormal angiogenesis characteristic of active endometriotic implants that might otherwise be missed. It replaces the need for any surgical instrument. It completely eliminates the need for histopathological biopsy. Correct answer is it highlights the areas of hypervascularity or abnormal angiogenesis that is typical of endometriotic implant. Next question. A surgeon injects ICG intravenously to assess the vascular perfusion of the rectal anastomosis following segmented resection for bowel for endometriosis. Under NIR light, 2 centimeter segment of distal bowel lobe remains completely dark. What does this dark zone clinically indicate? An excellent healthy tissue, localized ischemia requiring the surgeon to revise anastomosis, a more proximal and well-perfused zone, successful eradication of all endometriotic lesion. The answer is localized ischemia. When it is dark in ICG, we have to think about ischemia. So that segment needs to be re-anastomosis should be done. I think this comes to the end. And Pooja Chatterjee gets the first mark, highest score with 14,482. Vandana Gupta, 14,416. And Harini, 9149. And Harshada Tandulkar. Okay, so thank you and congratulations to the winners who has scored the highest marks. I think with this, we are coming to the end of this today's module. And for those who have missed the earlier modules, you can get in touch with her so that you can go through the other modules also in leisure. Thank you, Pallavi. Thank you, Jignesh. And thank you, all of you, all the participants and all the faculties and the chairpersons for your participation. And also, my special thanks to Dr. Pradeep Kumar Mitra sir for having permitted us to do this series of webinars. Thank you. Thank you, Dr. Suranjan. And thanks to